Hey, welcome to my podcast. My name is Dr. Brendan McCarthy. I am the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. Thanks for tuning into the podcast. This chair that I'm sitting in, I don't know if you guys noticed, this is a nice black chair. This is the first chair that I bought for my office's waiting room. When I got a nice office, my first nicer, not nice, it was my first nice-ish office in 2006. Before that, all the furnishing came from my living room. So I remember I saved up and I went to IKEA. IKEA just opened up in the neighborhood here in Tempe, and I bought these chairs. So I haven't used these chairs in a while. We kind of outgrew them in the practice, and then we put them in storage. And when we moved into this office, we pulled them out of storage, and I'm sitting in this chair, and it just reminds me of how I started out. Having a good feeling, good memory. It's a good moment. Anyway, I'm here for part 2 of the series finale. We've been talking about self-silencing in women and the impact it has on your health. We've talked about it through the lens of cardiovascular disease. We've talked about it through the lens of autoimmunity, through the lens of weight, through the lens of general metabolism. We've been having, and fertility, we've had a lot of conversations about this. This is important. And as I mentioned in the previous episode, part 1 of this is not something that's linked up commonly in medicine, which is ridiculous because they are. Women experience stress at rates higher than men do. It's foolish to just say that out loud without then spending the time to understanding what that stress is and caring about that stress, validating the stress. Women have had millennia of gaslighting, patronizing. Medicine has been not the best. It's time to change that. I want to do that with you. That's what we're here to do together. Understanding you deeply is an act of care. And then taking that understanding and applying it is truly practicing medicine as it's meant to be practiced. Traditionally, when you go to your doctor and you tell them about your stress, they will dismiss it. I had a patient who came in and told me she went to her other care provider, her gynecologist. She told her gynecologist about her libido being low and the stress around that and the relationship. And her gynecologist was a woman. Told her, just drink some wine. Have a couple glasses of wine. You'll be fine. That's what she told her. That's a woman. It's worse with men. A lot of times you don't even bring things like that up to male doctors. When you brought your valid worries and concerns to your physician, you were not listened to with respect and regard. And it even got to the point where they're saying things like it's all in your head. Yes, it is. And that's what we should be thinking about and caring about with you. It was a dismissal when they would say that, but I'm here to tell you it's not to be dismissed, it's to be treated and thought of, because the way you perceive stress in the world around you impacts your biology, impacts your immune system, impacts your cardiovascular health, impacts your weight, impacts your fertility, impacts you deeply. I am here to explain why it does that, how to treat that, how to undo these thought processes you may be having up here, recommending you to therapy, different types of therapy. EMDR therapy is the one that I use the most. I'm a big fan of that. So today's episode, I'm going to finish out. I'm going to talk about the role that self-silencing plays in weight gain and how I treat that. Now, you go to your doctor with weight gain, what are they going to tell you? Just stop eating as much. That's what they say. And I laugh because it's awful. It's the worst advice. It's just terrible advice. Terrible advice, because it's not always accurate. It's rarely accurate. And it's basically telling you what you already know. You already know somebody's going to say that. Hey, come on, that's not medicine. That's garbage. So when a woman presents to clinic with weight loss, I'm going to sit down with her. I'm going to understand why she's having weight loss. I'm going to ask her questions. I'm going to run labs. I'm going to validate her. Some people gain weight because they're overeating. Valid. That happens. And there's food addiction that happens to that. Why does that happen, Brendan? Well, when you eat certain foods, it increases serotonin and dopamine. Well, why would the woman want to increase serotonin and dopamine? Stress, trauma. You can't understand the woman in front of you until you really spend the time listening to her and talking to her, validating her. So the woman who presents to clinic who's overeating due to stress, what do I do? Just tell them to cut back on eating? How well does that work? Tell her she shouldn't stress as much? That's really effective. These are dumb therapies. You're hearing what's out there right now. I could prescribe you drugs, GLP-1s, sure. But the minute you come off the GLP-1, what is it going to do? You're going to gain the weight back. In some cases, worse, because we never dealt with the cause. Now, dealing with the complex, emotionally charged pathology of self-silencing in women is not something that's done easily and overnight. So when I have a patient who I've diagnosed with self-silencing, and due to a good history, she's the woman who doesn't communicate how she feels easily. She wants to keep the peace, so she doesn't raise her voice. Women are conditioned in many cultures to be meek, subservient, obedient, and docile. I know not all of you, but those of you who are not raised that way, stand by my side, I know, in cheering these women on to shed that. There's a beautiful woman in there that was conditioned to be small. She's worth all the effort. So when I diagnose that, there's the woman who looks at herself through the lens of how other people would perceive her. Does she have the right clothes? Does her hair look the right way? Her skin look the right way? Does she have the right family, right car, right house, right clothes, right furniture? How do people perceive her? And she only understands whether she's okay if she fits in correctly with the group. That's one. As I mentioned, the one who doesn't raise their voice, they do what everyone tells them to do. The self-silencing, where they have one face to the world, one personality. They show people they act all the time because their true self, they don't think their true self is welcome. When I diagnose that in a patient, say with weight, I can sit down with them and I can put together a protocol for helping them lose weight, for sure. It'll be targeted towards the cause of it, rooted in self-silencing. But if we don't treat the self-silencing, it just keeps coming back. So referring to therapy is very important. If the patient can't find a good therapist, or, there are times when people are not ready for therapy. I know that. And so financially, that's an issue too, because therapy is always going to be expensive. I know this. I'm not arguing that. There's other things we could do. There's groups, there's books, there's different ways that we can approach it. And our goal in medicine is to figure it out the best we can and do a good job and prove that we're doing a good job with results. Still, I refer to that, and that's on this end. In office, what do I do? Just because she's not finished with self-silencing doesn't mean I can't help her. How do I approach it? We know clinically and in the literature that emotional suppression is associated with hypothalamic pituitary adrenal axis dysfunction and dysregulation. We know that the adrenal gland cortisol levels are going to be surging up and down with that. We know this is a fact. We also know that causes insulin issues with insulin resistance and hyperinsulinemia, elevated insulin fasting in the morning. I want you to know the reference ranges for insulin in the morning are between like 2 and 20, I believe. Let's just, if you ever read a good book, you want to read a good book, Dr. Jason Fung wrote a book called The Obesity Code, right? Yeah, that's the name of it. Great book, good guy. I'm a big fan. But he talks about having that fasting insulin below 4 in the morning when you wake up. I agree with that. Getting your fasting insulin lower is very important for weight loss in the case of people who have stress-induced weight gain. And so what do? Intermittent fasting. When you want to do intermittent fasting with a patient, you want them to start off with as long as they can fast in a normal, healthy way, meaning they can fast as long and it's not that much of a strain. There should be a little bit of pressure on there, a little bit of hunger, but you can push through it, right? And we get that. And then you want to, from there, slowly build out the fasting window and try and get that fast out beyond 16 hours, which means you'll only consume water, black coffee or black tea, nothing sweetened, no sweet flavors, nothing. But you fast for that 16 hours, you push out to 16 hours. You don't really get weight loss in this population until you're somewhere around 18 hours, 20 hours. Now, I know that sounds insane, but that is biologically effective and it works. But the other part of it is you need to make sure you're eating very healthy during your window of time that you're eating. It needs to be good food. It can't just be like a greasy cheeseburger, which sounds good, but is not good. So we want to make sure we do intermittent fasting, but also we control the diet, what they're consuming during their feeding window. That's the time that they're going to be eating. That over time, intermittent fasting, you will see that patient's inflammation level go down, but also you'll see their fasting insulin improve as well, moving towards 4. And I've seen that. I've done that with patients with great success. I'm a huge fan for it and an advocate for intermittent fasting because there's no cost attached to it. It's just you. It's just the effort over time. If you fail, and you're like, I can't make my 16 hours stay, I can do 15, fine. Stick with 15 for a little while, then push it out to 15, go to 16, 17, 18, push it back up. Just don't always take it as a failure if you can't keep there. If you eat really not well during the window of time you're eating, then try fasting. I promise you it's harder to fast if you had like a lot of, junk food during your fasting window. So you want to try and make sure that fasting window really is a healthy time to eat. There's different tools we use to help patients monitor their diet, different platforms and apps we use that help a lot. But still, it is a basic thing to do fasting. What else? Testosterone replacement therapy is important with women when it's low because, when women have low testosterone, they perceive stress through a different lens, not as good of a lens. And it's more of like you feel defeated in the face of stress right away. I'm not advocating for supraphysiological levels of testosterone. I know in some journals, the American Family Practitioner, that's published by the American Medical Association, has an article in there talking about testosterone replacement therapy. And it's not that old. It's been around for a little bit. But they talk about using supraphysiological doses of testosterone in some cases. I want you to know I don't advocate for that. I don't agree with that. I believe using physiological dosing in women is very effective, very important. What does that do? It helps improve your natural feminine muscle tone that you're supposed to have. It improves insulin sensitivity, absolutely. And it improves the way you perceive stress, which means you're not going to have those same cortisol surges. See how this stuff works? When done right, you're like creating a symphony and you're approaching the whole of the woman. And that's who you are. You're the whole woman. You're not just the self-silencing. You're not just the side effect of the self-silencing. You're a whole person. There's a lot to you. And we can use all of that together to come together to create something beautiful. So yeah, testosterone's part of it. Thyroid support, when you're under chronic stress, as I mentioned in the previous episode, chronic stress really does impact the way your thyroid is metabolized. So your body makes T4 at the gland. T4 is the precursor. Okay, that's fine. It does its thing. It goes into circulation. But in circulation, it gets converted into something called T3. T3 is the active hormone that does the work, or triiodothyronine, that does the work. The enzyme that converts it over is called 5'-deiodinase, 5'-deiodinase. Now, if you are under stress, that enzyme 5'-deiodinase doesn't work very well. It turns into something called 5-deiodinase. It loses the prime, right? So it's 5-deiodinase, not 5'. What does that do? It makes something called reverse T3, which is an imposter T3. It's a version of T3 that doesn't work. It's a blank, so to speak. And that in circulation goes around and it doesn't do anything. It blocks the thyroid receptor, basically in effect slows everything down. So when your patient presents to the clinic with chronic stress, weight gain, and they have that issue with self-silencing, I run my lab, I'm gonna run a T3, a free T3, a free T4, TSH of course, but I'm also run reverse T3. And I'll see if they're converting their T4 into reverse T3 too high of a rate. Then I prescribe around that. What do I do for that conversion? How do I improve it? Zinc, selenium, sometimes ashwagandha and schisandra. And people are like, that's hippie, Brendan. That's not real medicine, Dr. McCarthy. Yeah, but my labs prove it. I'm not going to put fat on that protocol. I don't agree with that. I don't like protocols where I can't prove it did what it's doing. I'm not going to say, oh, yeah, this sounds like cool. Why don't you take this? No, I'm going to run the lab to verify I had effect. So 5'-deiodinase is definitely impacted by cortisol. I know that, and stress. That's the stress cortisol. That's 5'-deiodinase is really messed with, and it turns to 5-deiodinase. I know that zinc and selenium restores that. So I know I'm going to get that 5' back. I know ashwagandha, there's enough research showing that helps. I know schisandra has a little bit of research too in there. but it doesn't mean anything in the literature unless I could prove it in you. So we run the lab a month later. I see if that reverse T3 is reducing down and the free T3 is going up. Sometimes I need to prescribe thyroid. That happens. Sometimes I'll do it. Doesn't mean you're on forever. You're on it till you don't need to be on it. I don't use suppressive doses. There are some times where that you need suppressive doses. That's a different creature. It's a different conversation, different lecture, podcast thing. But this is a simple protocol for thyroid. What else? Cold plunges. Cold plunges are fun. Cold plunges help the way you respond to stress. It helps put you back into that parasympathetic state. Not every woman I know loves cold plunges. I got you. My wife kind of does, but doesn't. She does until she doesn't. She likes the idea of them. But she's been going to the cold plunge lately, cold plunge place here in the valley. It's fun because I'm like, hey, let's jump in this river. It's really cold. She's like, no. But, I try and get her to do it anyway. Still, cold plunges, that helps modulate your sympathetic parasympathetic, as I mentioned. One of the ways to monitor that, using an Oura ring or using a Whoop band or certain watches or different ways that look for heart rate variability, which is a way for you to test how your body's responding to stress in real time. So if cold plunges work for you, you'll be able to see it on that band, proving that it worked. What if cold plunging doesn't work for you? What do we do then? Is that a waste to have bought the ring to see if it worked? No. We try box breathing, where you're breathing 4 seconds in, hold it for 4 seconds, out, exhale for 4 seconds, hold it for 4 seconds. That's that circular breathing. That works. That'll work. You have to do it for a little bit. You have to do it for a few minutes, 10 minutes maybe, but it'll work. Give it time. But if that doesn't, go back to the cold, put some ice packs on your neck, right up here, at the stellate ganglion or the vagal, put it right at the vagus, right there. Cold ice, right there. 20 seconds on, maybe a few minutes off. Go back and forth, over 10 or 15 minutes, try that, back and forth, and see what your heart rate variability is doing there. The more you're able to get yourself into that parasympathetic state where the heart rate variability has gone up, meaning your heart's more variable, meaning your heart's more relaxed, less sympathetic stimulation, we're doing our job. That's good. So far, this is not big stuff. Testosterone, it's hard to find a good doc to prescribe it right. I get you. That's valid. Still, I'm not prescribing anything crazy in here, am I? There's no bariatric surgery in this one. And I'm not against bariatric. I'm not against, I want the best for you. And it doesn't mean I'm going to wait till it gets so bad that that's the only thing that works now. Final one is going to be rapamycin. And this is one I get in nice discussions with pharmacists from time to time. Rapamycin is a medication that was approved by the FDA, I think like a while back, but it was originally approved as an antibiotic. Not the best antibiotic, didn't do a very good job. And then it was released because it, at a certain dose, will suppress your immune system and prevent organ rejection in the case of like a kidney transplant. So pretty high dosing of it, that works. What we know is that rapamycin improves metabolic flexibility, and it also reduces mTOR-linked insulin resistance. And I'll cite that in the literature because mTOR is a mammalian target of rapamycin. They named this after rapamycin. This is fascinating. But rapamycin is a unique medication. You can't just prescribe it randomly. You have to be very cautious with it because it can be immune suppressing. So when you do it, you have to make sure you're doing it at a certain schedule. You have to pulse it, and you have to monitor the white blood cells in the patient. Does it work? I've had good success. I'm not going to lie. I like it. But you have to monitor it. Your doctor has to have their eyes on it and doing a good job. So please be aware of that as a possible therapy as well. So that's not all the approaches I do for weight loss, but it's kind of an approach I do for women with self-silencing, stress-induced weight gain. This is some cornerstone stuff I do here. There's other things I'll throw in there as needed. I'm not against GLP-1 medications. I'm just against doing GLP-1s without doing the work around everything else besides that, because just taking a GLP-1 to cut down your weight, it's not enough. Because once you stop it, you gain the weight back and sometimes even more. We can't let that happen. That's not good medicine. But still, if the patient presents to clinic and their weight is significant and this is causing health problems, I'm not afraid of GLP-1s. I'll use it, but I'll do all this other work too. Otherwise, I'm lazy. and doing bad medicine. And I'm not here to do that. And I would challenge every doctor that prescribes GLP-1s to get on track with this. Get on track with this. You're going to prescribe a GLP-1? Fine. Do the real work behind it. Make it where the patient won't need the GLP-1. You're not trying to put someone on medication that they'll stay on for the rest of their life, creating a piggy bank for the pharmaceutical industry that made it, or the whatever pharmacy that you're getting from. That's not our goal. That's not our jobs as physicians. Our jobs as physicians is to cure the sick. To cure the sick. Do our best. Apply everything in our mind. We vow to do that. So don't just write a GLP-1. Do your work. Do your work. What else we got? Autoimmune. I'll finish on that one because I love talking about autoimmunity. You know, I love talking about autoimmunity because you don't get enough of it. You need people to be out here talking about autoimmunity with you, because it's not enough to just prescribe you a base medication, the medicine du jour that you're seeing on the TV, the next ad that comes out. I mean, there's all these different biologics, but I'm not here to talk about that. I'm here to talk about all the other things around that. Now, I'm not afraid of prescribing those, and I do. That's when necessary, I will. But just like a GLP-1, that's not enough. It's not enough. It's not enough. When your patient is self-silencing, so I have a patient presents to clinic with autoimmunity, and I want to do a good history, as I mentioned. I'm going to understand the sources of her stress in life. I'm going to do my work up the pathway to figure out what could be contributing to it. Of course, I'm going to treat pathology as I see it in this moment. I'm going to prescribe as necessary, but I'm going to understand the cause up above it so that I can treat the best that I can with that woman. As I mentioned in the first episode, just kind of recovering that a little bit now. Prolonged self-silencing triggers that chronic cortisol. It triggers anovulatory cycles, so there'll be low progesterone. Basically, it promotes the immune system to move towards something called Th2 immunity. You're skewing more towards your immune system being moved over the wrong way. And that creates that environment in your body where it makes it easier for you to have that autoimmunity. This is creating that microenvironment between your immune system and your body, your cells of self. That microenvironment I talk about in previous episodes. That microenvironment is getting more and more triggering your body, moving more towards autoimmunity, where you can't recognize yourself because you're pushing more towards that Th2, and you're downregulating that T regulatory cells, T cell regulators. And so our goal is to try and restore that balance in the individual in front of us. Low-dose naltrexone really helps with that T cell regulatory component. It reduces glial cell priming in autoimmune models. It's low-dose naltrexone for autoimmunity is pretty magic in my experience. I'm a big advocate for it because I've seen it work again and again and again. But it plays a role with modulating that space between the cells of self and the immune cells. Low-dose naltrexone is one of those tools that has a high yield with a low adverse impact. The worst thing that can happen is you're going to have some dysfunction with sleep. You may notice some weird dreams. That's it. It's a low-cost therapy as well, in my experience. Now, there's some compounding pharmacies that are, there's like, this is the new thing. Everyone's going to charge more money for it, and they do that. I know this is not my favorite thing. But the impact low-dose naltrexone has on inflammatory pathways, and the impact it's going to have on resetting the immune system is there. It's valid. It's proven. So when I prescribe it, I'm going to do my labs around it to make sure the dose worked. Between 1.5 and 4.5 milligrams is the dosing we'll use. And we're going to verify with lab work that we've had benefit for that woman in front of us. What else do we do? Testosterone reduces interleukin-6. It supports the T1, T2 balance of immune system. I'll use that again, keep it physiological in those cases. That is helpful. And think about it. Men, we don't have autoimmunity like women do. Testosterone does play a role here. Testosterone plays a role. A lot of it is hyperestrogen, low progesterone, truth, but testosterone does help in these cases. What else? Hydrocortisone at physiologic dosing. The thing is, like, you've had this hypercortisol surge from high stress, and over time it's become depleted. Now you're low. Now you're more pro-inflammatory. So we want to regulate the cortisol level in these patients. We want to make sure the cortisol in the morning is hitting like 16, 17. That's a good number. So we're going to treat to that, make sure it's getting there, and then monitor the patient. Over time, we taper the hydrocortisone back down. This is not a permanent therapy, but it's an important therapy to help modulate the immune system. Progesterone is funny because progesterone helps rebalance the immune system a little bit. But progesterone in women with self-silencing is tricky because progesterone is a relaxing agent. It's causes you to feel more relaxed. It's, it affects the GABA receptors. And so it's helpful, but I think in a lot of ways it could exacerbate a patient's self-silencing because they can ease into it a little more. Testosterone is helpful. Whenever I use progesterone in a woman with self-silencing, I really want to make sure I'm considering the use of testosterone as well for the impact that's going to have on the amygdala, because one's going to be more relaxing, anti-anxiety. That's fine, but I want that testosterone to be there for you to have that confidence and assertiveness, risk-taking, and boundary setting. So I don't like to overdo progesterone without testosterone in women with self-silencing. That's an important balance in my mind. Finally, again, yoga, I got this idea from med school. Dr. Howard, this is a long time ago, 23, 24 years ago. There was a rheumatologist in one of the towns close to me. And he opened up his clinic and he put a yoga studio in there. Rheumatologist has a yoga studio in his clinic. I love that man. That is a true physician in my mind. And he was someone I always thought I looked up to. And that was one of the first reasons why I wanted to put a yoga studio in my office, because that's a person standing by what he knows works. The impact of movement for stress, for autoimmune, for any kind of connective tissue-based autoimmunity, rheumatoid arthritis, all of these things is proven its benefit. So I always prescribe yoga as well in those settings. This has been an important series for me to do, and it has meant a lot to me to do. And I'm very thankful for the opportunity to do this with you. And to the degree it helps, I did a good job. To the degree it didn't, I want your feedback. I truly want your feedback. It helps me drive this podcast. My next series I'm going to do is going to be pretty out there. I'm nervous about doing it because it's really triggering for some people. I want to discuss the failings of medicine, which I already do, so that's not scary. I'll point it for where it is. But I want to point out the whole, how MAHA happened, Make America Healthy Again, where it came from. I'm not here to put people down or disparage thoughts or belief systems, but I'm here to explain how Western medicine has, or conventional medicine, or just insurance-based medicine, let's call it what it is, insurance-based medicine, has dismissed people so much that they have moved over to something that is not always the safest or healthiest. So thank you so much for tuning into this podcast. I truly appreciate it. Your comments are welcome, as I mentioned. Please like, share, subscribe, and I'll see you at the next episode.